Hi, everyone. Welcome. My name is Sunita Iyer, and I am a naturopathic physician and licensed midwife in Washington State. This is our May 2022 webinar on feeding and eating for kids, challenges, disordered eating, and our approach and biases. So we're going to talk about a lot of different things in this session. We're not going to get to everything, and given that this is a recorded lecture, we won't necessarily have the opportunity for Q&A, but we can develop a way for us to connect afterwards if you still have more questions. So thank you for having me. This is a topic that I'm actually really passionate about and have been for many years because of some of my own experiences personally and working with the pediatric population for 15 years and honestly even working with the pregnant population for that same amount of time, given that feeding and eating challenges comes up a lot during the course of pregnancy too. All right, here are some of the objectives that I have for us in this session. So we're going to talk a little bit about what are some of the big feeding issues that you might see in the younger population. And I want to say a note here for those of you who aren't necessarily pediatric providers, who don't consider yourselves now or ever to be a pediatric provider for infants, young children, or even adolescents. All of these people eventually grow up to be adults who become your patients. So much like I've said in some of my other pediatric topics for a lot of adult providers, it is never irrelevant to you, even if you don't necessarily see these people in your practice, because you might be seeing their parents, their caregivers, their family members, and these folks themselves as they come into your practice later in life. And we'll talk a little bit about what the impacts are in adolescence and adulthood from early feeding issues as well. So we'll talk about what some of the signposts are and some of the things for us to be aware of if we're seeing this early. In terms of what could be later eating challenges. And on the flip side, if you are seeing these folks later in life, how to think about and talk about some of their early feeding challenges and recognize how that might fit into the challenges that you're having in dietary suggestions, recommendations, or changes with your adult patients. Some of the challenges that we're going to talk about can develop into disordered eating patterns. Not all of them do, and certainly not in all people. And this is mostly for this to be on our radar and for it to become part of our mode of inquiry. And a big piece of what I want us to consider and challenge ourselves to think about in this session and beyond is our own biases related to what is healthy eating, what is healthy food, our own biases around body size and fat phobia. And additionally, how much of what we believe about what is healthy biochemically and or otherwise is a product of colonization and is a product of very culturally specific and exclusive doctrine. So we have a lot to cover. Let's get started. All right, here are some of the hows and why, or who's and whys. As I said, I have some of these experiences, and I like to tell stories, so I'll tell stories over the course of this as well. I have spent a lot of years working with these families and seen a lot of these issues arise, and so it feels for me like a natural progression to share some of this experience with you. I have also, in the course of the last 2 years in particular, been really struck by the incredibly biased, frankly racist, and fat phobic commentary by a lot of our colleagues in the naturopathic profession and in allied health professions. That if people just would eat quote unquote clean, and look a certain way and behave a certain way, they just won't get a virus that affects all people. And that probably provided the specific prompt to want to talk about this now as opposed to another time. A few disclosures. I want to be clear that I'm not representing any particular organizations or businesses in the presentation of this material, just my own clinical experience. I am a full-time faculty member at the University of Washington, Bothell, in the School of Nursing and Health Studies, but I want to also disclose that I'm not representing them in the presentation of this material. All right, let's dig into infant and early feeding. So even from the very beginning, and these are the conversations I have a lot, you know, being a midwife and a naturopath physician who specialized in pediatrics for all these years. I've worked with a lot of growing families. So from even from preconception and all the way through pregnancy and with newborns. So the conversation of infant and early feeding was constant, probably, you know, 15 hours a day, every day kind of thing. I talked a lot about what people also consider optimal nutrition. And what I want to unpack here in this is our biases, honestly. Our biases are not unfounded. So I want to say that first and foremost. They come from somewhere. They come from the education we've received. They come from our own life experiences. They come from the people and the bubbles that we surround ourselves with and we are surrounded by. So when our education, our knowledge, and honestly, as we get more experience in clinical care, that experience starts to sort of compound itself and continue to concur with itself, we can actually become more biased as we move further into our years, unless we are really, really critical about breaking those down and seeing where they are. And a huge piece of this for many of us who are involved in infant care and families who care for infants is our bias around the breast milk formula wars. To start, think about the patients who come to you or the parents or caregivers that you and family members that you care for and their biases around what is the optimal nutrition for babies. And a lot of what then happens in infancy, early childhood, later childhood, adulthood stems from these discussions. So this is a really great entry point, which is why I honestly have felt so privileged, and my clinical practice always felt very exciting because it felt like I had the opportunity to be influential at a time that could really change the course of how people move through the rest of their healthcare journeys with themselves and their families. There is something very special about what people are willing to do in pregnancy and with newborns in terms of the changes they're willing to make. At the same time, there is something very deeply impactful about the biases that can form at this time and what we concur with, what we support, and what we challenge. And one of these things is the breast milk formula thing and the prenatal nutrition. If we get mired in that discussion of like breast milk is absolutely best, specifically fed directly from the breast, not necessarily even pumped or via chest feeding in other ways, and certainly superior to formula. If we get entrenched in that way of thinking early on, it can set the stage for the way that people become entrenched in their ways of thinking about nutrition and health and food and feeding as we go along, unless we check those assumptions. One of the things that these early conversations in feeding or about feeding are about is the concept of optimal humans. And I say it that way because it's not untrue. When you really dig deep, when we use our skills to ask more questions, but why do we think that breast milk is superior to formula? Okay, yeah, great. It has the antibodies, it has the enzymes, it has the cytokines, it has the immunoglobulins, it has the nutrients. Yeah, it's action-packed, that's great. And there is something beneficial about being about a parent being able to provide breast milk for their child. From a hormonal standpoint, from a satisfaction standpoint, there are benefits. One what is underlying that? And very often when we really start to dig deep, there is the idea that there is an optimal way of growing human beings. And I want you to challenge yourself about whether you believe that. I will tell you, from having literally cared for thousands and thousands of, at this point, probably tens of thousands of families from even my years in public health, tens of thousands of families, I have not found that the babies who were grown solely over breast milk are superior to the babies who were grown solely off of formula. I gotta say, I know that the research is out there that says that, babies who receive exclusive breast milk versus 50-50 or some, dilution thereof and or 100% formula, that there are differences in their immune performance. Yes, I do think that that is possible. And there are so many other variables. So part of why I am spending some time on this, even if you don't necessarily spend a lot of time caring for babies in your practice, is this is a great question to ask. What was your relationship to that early feeding? What the content, honestly. In addition to that there could also be a lot of very early trauma, both for the parent and the baby. And we'll get into that in a moment. If there were a lot of difficulties around breast milk supply, latch, structural issues, breast milk tissue, or breastfeeding tissue, there may have been a lot of trauma in there as well. So that question can be multifactorial and have many responses as well. Another thing that I want to spend a little bit of time on here is elimination diets. For those of you who are caring for new parents and their young children, their infants, many of us have, for a lot of years, felt pretty strongly that elimination diets for brand new parents and for people who are providing breast milk, it can do far more harm than good. Yes, there are certain things that babies react to in the milk. I will tell you flat out that, my personal experience, when I was drinking milk in my coffee, my baby puked way more. When I had that really hot Thai food and I pumped, and then that day was bad, and then 3 weeks later he had that pumped Thai food milk, that day was bad too. There are things that babies react to in our milk, and that is a whole talk in and of itself. We can talk about why that happens. We can talk about the permeability, the intestinal permeability that carries over from pregnancy, that can still be present for some weeks and months in the breastfeeding or breast milk provision relationship. But I want us to think about how we use allergy elimination diets or allergy prevention recommendations judiciously in early feeding relationships. This can do far more harm than good. And I want us to think about it from the perspective of, okay, when you're actually removing things from a person who's providing nutrition literally for themselves in another person, that calorie restriction that will inevitably happen can be very damaging to the health of both those people. At the same time, the messaging that we provide at that time about, well, if you just do this, your baby won't have these allergies, there is actually very little evidence to support that's true. And again, that can cause a great amount of fear, bias, and calorie restriction that can be harmful to the parent. So it may not seem like this early feeding can set the stage for so many things that you're seeing in your adult patients, but it actually can. And this is a great period of time for you to actually get curious about, even in your adult patients who either have some disordered patterns of eating already, who are struggling with diet changes, or may have some trauma around food and digestive issues. All right, let's talk about what other things can actually cause distress and or trauma in the early feeding relationships. And this is tongue ties and oral motor challenges. And I actually see this a lot as a person who's done, at this point, many hundreds of tongue tie revisions and managed many early feeding issues, whether they're structural, oral motor, and or otherwise. There's a lot tied, unintended, into this particular scenario. Very often when people come with their concerns about tongue ties, one of the main reasons that people come to me anyway, is the difficulty with being able to latch a baby onto their breast, to produce sufficient amounts of breast milk, to transfer sufficient amounts of breast milk to the baby, and to have what they consider a quote unquote successful feeding relationship. That is the most common reason why I see these babies who are tongue tied or having feeding difficulties. But there are other issues that parents come with that they are reading about online. And I am not a dentist, so I can't speak really definitively about the dental issues that occur from tongue ties, but I do know from some of my adult patients that some of their own dental and oral motor issues or oral health issues have actually, and even just their orthodontic issues, have actually had some root in their dental issues. So even just putting that aside for oh, did you have a tongue tie? If you're dealing with some of these people, but very often one of the things that parents are bringing as a real fear is not necessarily even the dental issues, although that's part of it, because orthodontia can be quite expensive. But speech deficits, that there is a huge social stigma around having any speech impediment. Even though we have services that can help with that, and even though there are a lot of kids who even initiate with speech difficulties and don't necessarily continue with them, there is still a lot of social stigma around that. Very often where tongue ties or oral motor challenges are in play, there are usually difficulties with babies not gaining weight and or weight loss, which can be incredibly devastating, not only for the health of the baby, but also for the parents and the caregivers. And sometimes what happens at this time, because parents are like worried about speech deficits and worried about dental issues and definitely worried about the well-being of the baby, there's a tendency for us to go like, okay, let's do everything. Let's get some craniosacral on board. Let's do a tongue tie revision. Let's get some occupational therapy in there. Let's do pumping. Let's do bottle feeding. Let's do SNS, supplemental nursing system. And it can, just think about all of that right there. Even if you have never had to feed a baby yourself or have cared for people who do, that is incredibly stressful. And that alone can create a significant amount of trauma that can trickle into early childhood feeding, young childhood feeding, and then definitely into adolescence and adulthood. So while it may not be on your radar to consider, I don't even think about when I'm having difficulty with my patients around dietary changes or elimination diets or some evidence of disordered eating patterns. I don't even think to about tongue ties and early oral motor challenges. This is to put this on everybody's radar, whether you deal with young kids or you deal with patients who are well into their 50s, that some of those difficulties can actually be tied to these very early challenges and struggles, either because they were the parent that dealt with this or because they were the baby that actually had all of these things happen to them very early on, happen to their mouth, and happen around fear and anxiety around their own ability to ingest and grow from that food. So what do we see when we move into young children? Well, the most common thing that I have seen in clinical practice that people come to me for is my kid is picky, selective, won't eat anything, and I am super concerned about this person's nutrition, and or they are actually not growing that well. And we're starting to get concerned about, should we be doing a metabolic workup? Should we be looking at their hormones? Should we be looking into type 1 diabetes? Is there a reason why this child isn't actually developing along their normal milestones and or in terms of the growth chart along their own progression normally? So what could be happening here? Well, some of these young children could actually be the people who experienced tongue tie and oral motor issues. Some of these people could also be the ones who were quote unquote failure to thrive as newborns and infants. And not necessarily because there was insufficient feeding at one time, whether it was formula and or breast milk, but because there were so many feeding difficulties early on. So one of the things right off the bat to keep on your radar is all of these things we have already talked about can absolutely translate into these quote unquote picky eaters. And it is actually very common. Now, I want to be really clear here. Every kid who is failure to thrive, has a tongue tie, had any other kind of very early feeding issue will not necessarily become a picky or selective eater. But a percentage, and honestly, a relatively small percentage, you know, I would say from my clinical practice, 10% or less, will move on to become picky or selective eaters. There are other things, and we'll talk a little bit about some other contributions that can heighten the propensity for becoming a picky selective eater. So for instance, if kiddos are neurodiverse, if they are experiencing stress or anxiety, there are contributions that can then take those early infant feeding experiences and translate those into the feeding experiences as a young child. So some of the things to think about for your young children who are coming as picky or selective eaters, one of the things that has to be on your radar is those feeding issues. One of the things that has to be on your radar is neurodiversity. You need to be thinking about sensory overstimulation and processing, and not just like they're a super taster, but think about how much happens with eating and in the mouth. There is literally the tactile feeling of food in your mouth. There's the chewing. They're losing teeth at this time. Their jaw might be sore. They're growing in teeth at this time. There is a lot happening in their mouth, not necessarily because they have sensory processing disorder, and that could also be true, but because there is actually a lot of overstimulation happening in the oral cavity in this very moment. There could be sinus congestion, and that is actually affecting their ability to smell. And we know as clinicians that our olfactory senses have a huge role in our ability to taste. And that for many of us, that without the olfactory, we don't really taste very much at all. And without the ability to taste, food becomes an oral motor experience and not necessarily a sensory experience, and certainly not necessarily a pleasurable experience. So it could be sensory processing, it could be sensory overstimulation, or it could be sensory blandness, to be quite honest. One of the other reasons for us to consider is snacking as a caregiving strategy. I will say no judgment, because I have been the parent who had to learn. I'm a person who forgets to eat. I had a young person who never forgot to eat. He ate constantly. And I was constantly handing out something to, you know, quote unquote, regulate his blood sugar, to keep him fed, but also to, on some level, to manage behavior. If we were out and about, it was so much easier to hand him a snack because then to go home, then to stop doing what we were doing. And so I say this with as little judgment as possible. And I think that this is something for us to think about when we are having these conversations with caregivers. So what is the underlying need in continually feeding them, such that then they don't eat their actual meals, where they have a lot more opportunity for nutrition and diverse nutrition? One of the main reasons that I see a lot of kids in this kind of 15-month to 3-year-old stage kind of plateauing or not thriving, you know, from a growth standpoint, not necessarily from a physical milestone standpoint, is usually because the kids have gotten on a schedule of snacking. And there is a caregiving strategy for managing behavior. And again, it's not simply enough to tell parents, hey, don't do that. We have to talk with them about what is the underlying feeling there and what else can we do in those situations to get them what they need. And maybe their snack is their meal broken up into 5 parts. And then maybe we change our own mentality about how we eat meals. So I think another thing that parents struggle with kids at this particular age is that many of us were raised with, like, you eat 3 meals a day, you eat them at the table, we eat them as a family. You know, there's lots of social and cultural constructs that are built in that are not necessarily negative. However, they can influence whether or not we are willing to see feeding young children differently. Another story, my son is very active, and as a 18-month-old, he ran, just constantly ran, which means he was always constantly hungry, which means that I would honestly feed him and he would run. He would take a bite and he would run. It turns out that apparently I did the same thing. I used to run circles in the house, and my grandmother would stop me, and she would feed me a bite and I would run again. Not many of us think that, oh, that's great for digestion. That's optimal feeding. Not many of us think that. But the reality is, if we are trying to work with families and they are trying to work with who they have, we sometimes have to adjust our own biases and also help them adjust their own biases around how feeding happens. So there could be a lot of stress around the family eating culture, definitely around school schedules. One of the other things that I really want to highlight here is this is where very often, so parents often have a lot of anxiety about feeding kids just right, the optimal diet when they're growing them on the inside, and certainly when they're doing food introduction. But there is a lot of caregiver worry about it at this age too. And sometimes the thing that we identify as picky or selective might actually be the worry of the caregiver themselves, that the foods that the children are eating are bad or unhealthy. And if they don't learn how to eat, enjoy kale at 15 months, they're never going to learn how to enjoy it. I will absolutely swear to you, I hated all of those things until I was probably 19. I love those things now. It is actually never too late to learn how to love food. And actually building positive relationships with food has a lot more impact at learning how to love food than forcing it on kids when they're 15 months old. There is actually a good amount of evidence that caregiver worry affects late food introduction, and late food introduction can actually be one of the most common causes of selective eaters. And therefore the selective eaters that then end up having difficulty with growth or reaching their milestones. So one of the things we can do as natural health providers who have a lot of expertise in nutrition is to help them unpack some of that worry. What are you worried about? That bad unhealthy thing? Well, let me tell you something. You know what? A fed kid is a healthy kid. Let's get them fed in whatever way that we can. And let's start there. So part of this is unpacking our own biases and also helping the parents unpack theirs, because there is actually strong evidence that shows that when they are more worried about that bad unhealthy food, they tend to withhold, even if they don't necessarily realize it. So when we get to the older kids, what's up with them? Like, why don't these 8 to 12-year-olds just eat normally? Why are they still really selective? Why didn't they grow out of it? A lot of kids do, partly because they start going to school, they start, going to birthday parties, sleepovers, having friends, their world expands and they start to become exposed to other people, other families, other cultures, other ways of eating, other relationships to food. And maybe they become more bold, they step into themselves a little more, they become more independent. And so they want to try different things because it's not what you do in your household. There's a lot of reasons why we think that they should grow out of it at this age and why we normalize that. And so when they don't, what else is happening? Well, let's backtrack again, right? It could be that they had late food introduction. It could be that there was an incredible amount of caregiver or family worry about feeding them bad, unhealthy foods. And now at the age where they have started to step out into the world, they're seeing the world as bad and unhealthy and toxic around them. They're like, oh, I can't eat that. I learned from the time I was born that sugar is bad, that McDonald's will basically kill you. It's poison. I have a story about that one too. They could be the kiddos that actually were failure to thrive as infants, had tongue-tie issues, and had a lot of oral motor overload. So when you are working with this population, when I say older kids, I'm thinking kind of in that like 5 to 12-year-old range, which is a large span of time, honestly, from a developmental standpoint. There are a lot of reasons why they might actually be very selective. And a lot of that might actually be attributable to their very early feeding issues. So if you haven't gotten curious about that, it might not be just anxiety and digestive issues. Don't stop there. make sure that you investigate all the way to the beginning, and the caregiver approach or bias and healthcare approach or bias to what is healthy, unhealthy, bad, toxic, all of that. The other thing I really want to point out is body image stuff starts in this group, in the 5 to 12-year-olds. This is not a conversation that starts at 13 with your patients. This is not a conversation that parents should be starting with their kids at 14 years old. This is a conversation that starts at 6. And I mean that honestly, truly, and from a lot of experience. There are kids who are already pinching their rolls at 5 and 6 years old. There are already kids, and I'm seeing this in male-born people and female-born people. You know, I happen to be surrounded by, 15 male-born people all the time with my son and his friends. They are already very conscious of who's bigger, who's smaller, who's got more muscle on their body, who's got more abs, who's more chiseled. So the body image is not exclusive to female-born bodies. The body image is for everybody, and the messaging is early. And it starts from all the things that we say to kids. Oh, look at you, you're so strong, look at your muscles, that's a compliment, right? It's not necessarily a bad thing, but we are letting them know that if you don't have those things, is something okay? Mental health has not just dysmorphia and body health concerns, but overall anxiety, period. And now, especially in the last couple of years of the world around us is literally dangerous. What we eat, what we breathe, what room we walk into, what event we go into, what we touch has literally become dangerous. And we all know, and many of this may be true for many of you, that many adults are experiencing this. Kids are absolutely hurting from this. And I've had the opportunity to speak probably 3 or 4 times in the last year at different conferences about pediatric mental health. And I want to tell you right now that this is 100% true for kids in this 5 to 12-year-old range to some extent. And it absolutely might be feeding into whatever feeding challenges or difficulties or selectiveness you're seeing in these kids, that they're starting to feel like the world out there is dangerous, what they put in their body is dangerous, and they are feeling mixed messages about what is actually healthy behavior. At this point in their lives, they're also looking at their own gender identity, at their sexuality. And while they might be becoming very aware for some kids are still not quite certain where they land, especially depending on how normal it is for them to be explorative or how normal it is for them to be conformed. And sometimes food is a way that people exercise control when they feel like there are things happening to their body or there are things that are happening to them socially that are beyond their control. And I want to reiterate, and I want it to become, very clear to you that it happens as early as 5 to 12 years old. This is not simply an issue of just adolescence. So when we are talking about when you're working with your adolescent or your adult patients, it is important to not only investigate those infant feeding issues, early feeding issues, but also really specifically, how did people view their gender and their sexuality, their mental health, their body image at 6 years old, at 7 years old? I knew very early that I was someone who looked very different from other people in school. I was made very clear by people in school. So I already knew by 7, 8 years old. Now, this is specifically more related to race and also body size, that I was someone who stood out. Kids know really early where and when they don't belong. And as adults, sometimes we forget. We think that this is more a function of adolescence or even young adulthood. And this happens early, and some of these messages become the things that kids live into as adults. So how do all these things trickle into adolescence and adulthood? Well, all the ways we talked about thus far. There are all the sociocultural values for body size and shape and control are happening pre-adolescence. Many of the risk factors for developing disordered eating arise from some of those early eating conflicts, some of those struggles with food, and some of those really unpleasant meals in childhood. One of my, personal experiences is that while I didn't necessarily experience what I would think as an eating disorder, and I wouldn't characterize it that way, and I wouldn't diagnose it that way, I had a lot of eating conflicts with my family. I was an incredibly picky eater, an incredibly selective eater. What it turned out is that I had really bad digestive issues. But I also became really fearful about eating foods because I wasn't sure if they were going to hurt my body or not, but I couldn't tell people that. I didn't know how to voice that. The only thing I had control over is whether I actually swallowed that thing. And I would actually go to sleep with food stuck in my cheeks. It also rotted out my back teeth, and I had them pulled. So there were consequences. But there are a lot of reasons why kids do things, and very often it is not just that they had those challenges, but the conflicts over those challenges. The no, you better eat your food and clean your plate kind of mentality, or meals only happen at the table, or let's throw the kitchen sink at them and make the mouth and the eating, the first and foremost and priority of our entire lives. All of those kinds of challenges and conflicts and that anxiety and worry, it's not necessarily a good or bad thing. It just is, right? Something for us to be curious about can influence whether or not people develop disordered eating patterns later. Again, it is not a one-to-one relationship. There is a small percentage for whom that is true early on that can then trickle into those things. So when we are doing some discovery around eating disorders and disordered eating patterns in adolescence and adulthood, not just the events that happen and circumstances, but the conflict around it is really important for us to investigate. And honestly, statistically speaking, the presence of eating problems in early childhood or an eating disorder early on, like in sort of preteen and early adolescence, can actually be a very high risk factor for eating disorders in young adulthood. So when we are doing our discovery for our adult patients who are still struggling with disordered eating patterns of any sort, whether it's orthorexia or other eating disorders, there is a very strong correlation, and it is actually an independent risk factor in and of itself that very early feeding challenges can actually confer some of that risk later. I mentioned neurodiversity earlier, and I want to just highlight it to keep it in your mind. It is not true that all neurodiverse people and children are going to have feeding issues. Absolutely not. It is also not true that everyone who has feeding issues is neurodiverse, but there is a correlation, a concurrence between those two things. We do see some increased feeding difficulties in infancy and early childhood. We do see more food aversions, and we do see the social isolation that can sometimes happen as a result of the food issues or as a result of the neurodiversity compounding this entire picture of where we see neurodiversity and either food aversions and or disordered eating happening concurrently. So if you're working with neurodiverse adolescents or adults, it is really important for you to consider that there is a higher likelihood, although not a one-to-one relationship, that there were more feeding issues early on, and that can be one of the ways that you work with your adolescent and adult patients too. So here's where we work a little bit on ourselves too. Knowing the progression throughout from infancy all the way to adolescence is really important. But the other piece is for us to know where we sit. And this is something that I have struggled with over the course of my own life and over the course of my own professional trajectory. I love sugar, I eat sugar, I love candy. So I don't mean that I struggle with sugar in that I don't eat it. And I love bagels. So I'm clearly a carb and sugar fan. However, I feel strongly that in the course of my education, when I was learning more about natural health and eventually learned about something called naturopathic medicine when I was having my own health issues in my early 20s, I learned a lot of things about sugar, and most of that messaging was super negative. And the messaging about carbs at that point, well, let's see, this was in the mid 90s to late 90s. It was more about anti-fat at that point. But even the messaging about carbs was starting to be, big old thumbs down, right? Don't eat it. And I'm thinking to myself, well, I mean, I can't eat carbs, I can't eat fat, can't eat sugar. What can I eat? And what ended up happening is that I actually got sicker. I want you to do a little discovery on yourselves. How do you talk about sugar and carbs? Do you talk about things like, reducing carbs? It even still comes up in groups of people. I'm sitting with a group of mothers, and all of our kids are finishing 5th grade together this past week. And one parent says, "Oh God, I got to get back on track. I've just been losing it with the carbs." I'm like, "What do you mean?" "Well, I've just been eating so many carbs." And I said, "Well, I mean, carbohydrates, I mean, they literally hydrate muscle. They provide energy for muscle. Using your muscles means that carbohydrates are necessary. What does too many carbs look like?" And I think being a little more investigative about, like, okay, you mean refined flour. But what starts to happen is that everyone throws a baby in the bathwater out together, right? Like, "Oh, I don't eat sweet potatoes. I don't eat white potatoes. I don't eat French fries. I don't eat." And when we are having those conversations with our adult patients, kids are listening. Always. They're always listening. My kid can hear something from like 17 miles away when he's asleep and then repeat that conversation to me. They're always listening. And that messaging, if the adults are ingesting that, that means 100% those kids are getting that message too. How do you feel about carbs? I want you to challenge the way that you talk about it. I want you to challenge the way that you feel about it. It is not unreasonable to think that we also learned in our education as naturopathic physicians that carbs had a negative charge to them. And I definitely feel that in a lot of ways, I became more critical of my diet, and I became more critical of my physical appearance in the years that I was in naturopathic medical school. I actually became fearful of eating certain things during that time because I felt ashamed to show up to school with a certain meal that didn't look a certain way. I felt, and honestly, people would say things. I remember very specifically one of my classmates would leave at lunch and come back with McDonald's, and people would literally throw her dirty looks while simultaneously also really craving those McDonald's French fries. And I have done things like this. One of my stories, my McDonald's story, we're driving by McDonald's on Lake City Way, right over here in the Seattle area. And my son looks at that place because it's got a big play place, a ball pit. And he says, "I want to go there." And I said, "Oh, no, we can't go there." He said, "Why not?" And I said, "Well, you'll probably get needle sticks from that ball pit, and the food is poison anyway." I'm definitely a person who says things offhand and sarcastically. I also grew up at a time and in a place where needles were all over our beaches on the Jersey Shore, and there were actual ball pits that were closed at McDonald's because there was hepatitis B in them. So it's part of my lived experience, but I probably didn't need to say it offhand to my toddler, right? And to insinuate that the food was poison, which it's not. About a month later, our friends come over with their son, who is literally the same exact age. This kiddo now eats everything, by the way, but was a super selective eater. And he wouldn't eat anything we made for dinner. So his parents brought him McDonald's so that he would have something to eat and be able to sit with us at dinner. That is really important for him to then be able to be socially and culturally part of the family meal. My son asked me at bedtime that night, "Mama, why did his parents feed him poison?" I mean, what an asshole I was, right? But think about that. Think about the things that we say, think about the things we think, and think about the things we communicate, because the kids are listening. When you are eliminating things from people's diets, and specifically when you're talking to them about carbs and sugar, you really need to go back in their history and all the way to the beginning, all the way to the early programming that they may have received from early infancy. And if they don't know, that's a great idea. That's a great place for them to get curious and to ask if they're able to, if their families of origin, if their birth parents are available to them, so that they can actually ask, what was early feeding like for me? What was it like for you in trying to feed me? Because that anxiety translates. The other thing about when we diminish carbohydrates, when we diminish sugar, we also diminish cultural forms of eating. Every culture in this world has a way that they celebrate with rich, sugary, delicious foods, every culture. And so when we actually demonize baked goods, sugar, carbs, we are actually encouraging this person to disconnect from cultural ways of eating, from celebratory ways of eating, from joy, and from family culture. So when you are having those conversations, one of the key things you have to ask and get curious about is, what kind of foods bring you joy? And if it happens to be sugars and carbs, hey, let's have a conversation about that. Because I really want to work with you on your health goals. And I want to make sure that we preserve connection to your cultural ways of eating, your family culture, your family of origin, and your joy and your celebration. It is not okay for you to not have joy and celebrate, especially in times like these, and to be disconnected from your culture because carbs are bad. Why do we also define certain foods certain ways? Well, let's think about it. A lot of it is because it's based in biochemical nutrition that comes from research, which, if you don't know by now, is heavily biased. There are certain people who get to do research. There are certain people who decide what the research questions are. There are certain people who get to disseminate that research. That research then gets disseminated to healthcare professionals and institutions, who then also layer their own bias upon it. So nutrition and what we consider healthy food absolutely is rife with bias. It is absolutely rife with racism, as are all of our systems, the healthcare system, the educational system, and all of our systems of research and access to data and evidence. So when we define healthy food, we have to think, well, how we are defining it. We are defining it based on standards set by institutions that are inherently colonized, racist, and biased. Does your definition of healthy food include things that are fried? Does it include roti? Does it include rice? Does it include MSG? Why doesn't it? And who does that leave out when your diet only looks like steamed salmon, boiled kale, and some quinoa? I'll tell you, look, it doesn't come in my traditional diet. I actually don't enjoy that meal at all. However, when you define healthy food, when you define, like, say, for an elimination diet, and you say, okay, here are all the things that you can eat, and these are good foods, and you got to take potatoes, rice, soy sauce, fried foods, wheat out of your diet, what is left of the things that people connect with? And why? And what systems, honestly, of oppression are you contributing to and participating in when you make those recommendations? One of the things that, if you're going to make a lot of nutritional recommendations, elimination diets, learn about the biochemical breakdown of foods from foods around the world. Know how to include foods from around the world into an elimination diet that someone can eat. If your elimination diet still looks like the one that we were prescribed in school, I'm going to tell you right now, it does not include foods that people eat all around the world. And I've had this experience as a clinician. Early on, I recommended a diet, and a mom just sat there and she started crying. She's like, I don't even know how to feed my family if I have to eat this way. My own parents have gone through this, where they've had providers recommend this to them, and we've literally had to do our own research as a family. Luckily, they have me to find out, what can you eat out of our traditional foods where you still get all your nutritional needs met, you feel joy and celebration and nourishment from the food you put in your body, and you don't feel punished because of your health concern and now the treatment for your health concern. And I want you to think about whether or not your definition of healthy food equates with smaller bodies. Very often when people are coming to us to discover their health goals, there is one piece of us that is still tied into what their body size should be. And we need to be curious about that before we put them on elimination diets, before we start making recommendations about taking things out and what their goal is. in terms of not just, maybe their digestive issues, their mood, their mental health, all of those things are great, but does it also include a smaller body? And I'm not saying that's not necessarily a bad thing, but if that's really the underlying cause, we need to know that, and we need to spend more time being curious about that. So there are lots of bases for our biases, but these are huge ones. Racism is at the forefront, and even if you don't consider yourself or what you're recommending to be a racist ideology, if you have not adjusted it to be culturally inclusive, if you have not adjusted your dietary recommendations and your allergy elimination protocols to be culturally inclusive, you are still using protocols and ideologies that were based on systems, institutions, and practices that are inherently racist, fatphobic, exclusionary, oppressive because of the limitations of who's actually been able to be included in and represented in science and education. You are also perpetuating the sociocultural values and context of who looks like healthy bodies. You go on Instagram and you hashtag healthy, it comes up with light-skinned people, typically light eyes, long silky hair, not curly or kinky hair. And they're running, usually on a beach somewhere, and they're enjoying and laughing as they eat their kale and their smoothies. And that is a very, very strong sociocultural messaging and context that we were educated with, that we live in, and that all of our patients are also ensconced in as well. And we have to know that if we are using BMI for any of this, it is garbage, it is racist, and stop using it. So what can you do? Check yourself. Look at your own house, literally and figuratively. Look around at your own house. Look at the messages that you send in your own homes based on what you buy, what you don't buy. When you go to the store, how do you read labels? How do you talk to people in your family and your kids about labels and what are the right foods? Think about your own family eating culture. What brings you joy in eating? Sit down and actually take inventory about where joy, celebration, and actual nourishment from food comes from. Start there, because if you can get curious with yourself, if you can personalize it, then you can actually start to extend that out to your patients. You can ask them to do that because you've done it yourself. In your questioning, in your treatment plans, are you addressing family eating culture? Not just what do you eat, what is the content, the biochemical breakdown, but how do you eat? Where do you sit? Is it quiet? Is it chaotic? Is it well lit? Is it dimly lit? Do you eat on beautiful plates? Do you eat slowly? Do you eat quickly? Do you watch TV? Find out all of these things, because a lot of this will tell you, is there joy in their eating, or is food a punishment, and why? And where did that come from? And how are we contributing to the joy or the punishment in their food? And what is nutrition about? Is it about making us bodies smaller? Is it about fitting into certain clothes? Is it about actually experiencing nourishment in our body, strength? Is it about the concept of optimization and having the perfect child? There are no perfect children, by the way. They're all little crazies. And awesome. And use your own motivational interviewing. When you don't know what to do, ask questions. Get curious. Don't tell. Just stop and ask questions. People come to you because you have a lot of expertise. We've actually taken a ton of nutrition classes just in our didactic education alone in naturopathic medical school. It doesn't even include our continuing education over the years. However, people are still the experts in their bodies. They live their chronic conditions or their pain or their food challenges. You don't. And so getting into their life is one of the most impactful and healthful things and helpful things that you can do for your patients. I hope I've left you with some things to consider. I hope I've left you with more questions than you had going in. If you have questions and that there is a way after this recording for us to connect with each other, I'm happy to be available to you. And if there's a way for us to continue this conversation, I'm always excited to do that, about what is the next step in our profession, about how to be more culturally inclusive, less biased, and more curious about food. Thank you so much for having me. It was a great pleasure, and I hope you got something out of it. Thank you.